Let's talk about assessment of the respiratory system and the thorax. During this module, we'll talk about anatomy, taking a history, and doing a physical exam on this body system. Let's start first with anatomy. In terms of anatomy, you need to remember the sternum, the manubrium, the ribs, and the scapulae. Singular scapula, plural scapulae, because it's a fun word. Remember that the sternum is made up of the manubrium on top, it's sort of like a short squatter shape, the body of the sternum, that's that longer, larger piece, and the xiphoid process right at the inferior aspect. Note that the ribs are numbered 1 through 7 true ribs, 8 through 10 false ribs, and 11 and 12 floating ribs on the posterior aspect. Note that that first rib is really sort of tucked under the clavicles. This is an important concept. You're going to need to be able to count ribs, and I'm going to show you how. Where the manubrium and the body of the sternum join, that's the angle of Louis, or the sternal angle. And I want you to use your fingers to feel, to see if you can locate the area where the manubrium and the body of the sternum articulate. There's a little bit of a divot or a dent in there, and then a little bit of a bump inferior to that. The bump is the superior aspect of the body of the sternum, and that little divot or that little dent is the inferior aspect of the manubrium. That dent is called the angle of Louis, or the sternal angle. Up here at the superior aspect of the manubrium is a suprasternal notch, or the jugular notch. That's not what I'm talking about. I'm talking about the notch at the inferior aspect of the manubrium. Some people, you can even see that notch. Other people, you're going to have to palpate to find that little dent. That's a really important landmark we're going to use for a couple of different things. The first thing we're going to use that for is to count the ribs. If you have your finger on the angle of Louis and then move it just adjacent to either left or right sides, your finger will be on the second rib. If you keep your one finger on the second rib and then move your next finger down into sort of the divot below that rib, you know that's an intercostal space, or the space in between the costus, the ribs. So we have the second rib, and just below that is the second intercostal space. Using your next finger, and you feel the third rib. Below that is the third intercostal space. And walking your fingers down, you'll be able to feel all of the ribs and all of the intercostal spaces. So the intercostal space is numbered for the rib above it. And this way, we can find all of the latitude landmarks of all the findings on the thorax on the anterior aspect. If we look at the posterior aspect, you can use the vertebraprominens, which is C7, as your way of counting the vertebrae down. There's 6 more cervical vertebrae above C7. There are 12 thoracic vertebrae, starting with T1, just below C7, and then 5 lumbar vertebra at the inferior aspect of the spine. But the vertebraprominens C7 is easy to see on many people, certainly easy to palpate on everybody. So now we've got latitude lines on the anterior aspect and the posterior aspect, so we know exactly how to document our findings. Now let's look for some longitude landmarks. We know that if you draw a line down the very center of the body, that's called the midsternal line, because it goes right through the sternum like that. If you think about the clavicle, if we draw a line right through the center of the clavicle, so the midclavicular line runs sort of through the nipple of each side. That's called the midclavicular line. So we have one on the right and on the left. Don't forget your right and left. It's the patient's right and the patient's left, even though we're usually facing them like you're facing me. So my right is the right we're talking about, even though it looks like the left to you. At the lateral aspects of our chest are the anterior axillary lines, so that the anterior aspect of our axilla and the lateral aspect of our thorax. If you look at a patient from the lateral aspect, you'll see the anterior axillary line, the posterior axillary line, and then a mid-axillary line. So now we have longitudinal lines on the anterior aspects and the lateral aspects of our patient. On the posterior aspect of our patient, we've got the spinal column, we've got the vertebrae, and the scapula with which we can describe our findings. A lesion, for instance, is so many millimeters to the left of the right scapula, or left lateral to the vertebra at the level of T10, or I auscultate a particular finding at the anterior axillary line, fourth intercostal space. In terms of anatomy of the respiratory system, there's upper and lower respiratory systems. The upper respiratory system is really the larynx and superior, whereas the lower respiratory system is below the larynx. It's the level of the trachea and inferior. We've got the bronchial tree, which includes the primary bronchus and the bronchioles, the alveoli, and don't forget the diaphragm, which is a muscle that moves up and down. It moves up, relaxes when we exhale, it constricts and moves down when we inhale. The lungs themselves are divided into 5 lobes. This is an important concept because a patient can have a disease process in one lobe and not in another. So we have to be sure to assess all 5 lobes thoroughly. We use these abbreviations to refer to the lobes: right upper lobe, right middle lobe, right lower lobe, left upper lobe, left lower lobe. Why do you think there isn't a left middle lobe? That's right, there's a heart there using up that space. It's important to understand where these lobes lie inside your patient because most likely your patient is going to be wearing skin on their outside, so you need to be able to figure out, if you put your stethoscope in this area of skin, which lobe am I listening to? So for instance, notice that the upper lobes are really mainly accessible from the anterior aspect. They are barely accessible from the posterior aspect, just the very tops, and the lower lobes are only accessible from the posterior and lateral aspects. And what about that right middle lobe? It's tucked right sort of under the right breast. You can only access that right middle lobe from the right lateral aspect or the anterior aspect. As you're listening to the lungs, make sure you're moving the breast tissue so it's not inhibiting your auscultation of the lungs. Breasts are mobile. Ask your patient to move the breast. Make sure your stethoscope is underneath the bra so you're not hearing a lot of artifact sound. In terms of a history in the respiratory system, we want to ask all the common questions like past medical history, past surgical history, family medical history, any medicines, over-the-counter, prescription, supplements, and what allergies do they have? What is their full review of systems? Questions we want to ask that are specific to the respiratory system include, has this person had a cough? Besides the regular symptom analysis we would do for this system, make sure you ask if that's a dry or productive cough. If it's a productive cough, is the phlegm thick or thin? And what color is it? Has this person had shortness of breath? We abbreviate shortness of breath, SOB. No, really, it's true. In nurses, SOB means shortness of breath. There's another word, dyspnea. Dyspnea really means difficulty breathing. And it's not exactly the same as shortness of breath, honestly. You can have one and not the other. But for the sake of this course, we'll consider shortness of breath and dyspnea pretty much the same symptom. Has this person had any chest pain? If so, was it at rest or with physical activity, or both? What is this person's smoking history? If they have been a smoker, how many pack years do they have? Has this person had significant secondhand exposure to smoke? What environmental or occupational exposures might this person have had? Do they live in a new building? Do they live in an area of town with a lot of diesel emissions? Are they exposed to smoke or chemical fumes? If they're miners, firefighters, construction workers, transportation, cleaners, these are just a few occupations that are going to have potentially significant occupational hazards that could affect their respiratory health. Has the patient traveled recently? Have they had any exposures to sick people? Another kind of strange question we're going to ask in their history is, how many pillows do they use to sleep? Well, that's kind of strange. Why are we asking that? Certain kinds of respiratory illnesses mean that it's very hard to breathe if you're lying supine. So if someone must have 3, 4, 5 pillows or be sleeping in an easy chair, only partially recumbent in order to breathe well at night, we call that orthopnea, O-R-T-H-O-P-N-E-A. You'll notice this P-N-E-A, it means breath, like in dyspnea. Dyspnea means difficulty or pain with breathing. Orthopnea means you need to be propped up on pillows to breathe. And we actually measure that as 3-pillow orthopnea, 4-pillow orthopnea, 5-pillow orthopnea. Now you've got a good history. Let's move on to the physical exam. At the beginning of your physical exam, do a good general survey. What does this person look like and how do they seem? Think of the broad categories of behavior, physical appearance, mobility, and body build. Note particularly findings, including pertinent negatives, that bear on the body system at hand. General survey findings particularly relevant to the respiratory system include: do they seem to need to make an effort to breathe? Or are they relaxed? Are they anxious? Are they conscious or unconscious? If someone is having a hard time breathing, unless they're unconscious, they're likely to be looking or acting somewhat anxious. Are they on oxygen through a nasal cannula or on a ventilator? What does their face look like? What color is it? Pale? Erythematous? Are their lips blue? Are they puffing with their lips pursed? What position is their body in? Are they tripoding to give their lungs more space? Are they fidgeting? Are they completely still? Look at the shape of their chest. Are they barrel-chested? What is their body habitus? The physical exam for the respiratory system must start with vital signs. You need a full set of vital signs in order to do a respiratory assessment. When the vital signs are done, we're going to use inspection, palpation, percussion, and auscultation. Inspection respiratory assessment starts with the body habitus. Habitus means shape. Does this person have a barrel chest or not? We're going to compare the side-to-side diameter of our patient's chest with the front-to-back diameter of the patient's chest. Front to back, we're going to abbreviate A to P, which is anterior to posterior aspect. And what I mean here is the sternum to the vertebra. You're not counting the breasts, you're only counting the sternum. And you're going to estimate visually, you don't need to get out a measuring tape, this diameter, the anterior to posterior aspect, to the lateral or transverse aspect. And generally speaking, this diameter, front to back, is only about 1/2 of this diameter, meaning that a person is wider, usually, than they are deep. As opposed to like a fish that's deeper than they are wide. If the anterior to posterior diameter to the lateral diameter is approximately 1 to 2, that would be a normal finding. If, on the other hand, a patient has had cyanosis for many years, one of the adaptations of their body may be to actually grow their rib cage out deeper in order to expand their lung size. So you'll see it written AP to lateral equals 1 to 2 or AP lateral equals 1 to 1. And instead of lateral, sometimes they might use the word transverse. It's the same thing. Either cyanosis or edema in their hands or feet, in their fingers or toes. What's the color of their skin, their face, and the rest of their skin? Are they pale? Are they pink? Do they have redness? What does their voice sound like? Is it gravelly? Are they able to complete a full sentence? Or do they have to catch their breath in between the words? Then we'll move to palpation. We're going to do 2 maneuvers with palpation. One is called symmetric expansion, when we put our hands on the back of our patient near the bottom of our patient's lungs, with our thumbs maybe a centimeter apart, symmetrically. Ask your patient to take a deep breath in, and you'll be able to see your hands move symmetrically and rise up with each breath. If, on the other hand, only one hand moves up with a breath, or one hand moves a lot more than the other, that may help you pick up or visualize the fact that one lung is not inflating well. That's called symmetric or asymmetric expansion. We're also going to use palpation to assess for tactile fremitus. Fremitus refers to the vibration of vocalization through our lung tissue and through to our body surface. You're going to use the ball of your hand or the back of your hand at these positions on the patient's posterior and lateral aspects and ask them to vocalize repeatedly something polysyllabic like 99, 99, 99. You're going to compare the left to the right simultaneously to see if the vibrations are the same on both sides symmetrically, or is the right side stronger vibrations than the left side? Or the left stronger than the right, or they both decreased? Do you feel much stronger vibrations on the left or the right? Describe what you feel. And make sure your patient is vocalizing when you have your hands in all of these different areas. We want to know if the fremitus is equal bilaterally in all the different lobes of the lungs. The reason is this. There are 2 main buckets of respiratory disease: obstructive or consolidative. There's a whole lot of different diseases that belong in each one. So remember back in high school chemistry when you talked about the 3 states of matter: gas, liquid, and solid? Remember that vibrations travel best through solid matter. They travel the weakest through gas. and liquid somewhere in the middle. Tactile fremitus makes use of this concept. Lung tissue in a healthy person should be sort of somewhere in the middle, okay? It's not exactly liquid, there's definitely air or gas in the lung tissue if it's healthy and expanded. It's not solid like a table. It's somewhere in the middle. And as I vocalize, I'm creating vibrations starting in my vocal cords, but they move not just through the air to your ears, but also through my body and through my lungs to the surface of my body. If you have your hands on the posterior aspect of the thorax, lateral aspect, or anterior aspect of the thorax, you should be able to feel those vibrations as well as hear them in your ear. What we're talking about with tactile fremitus is just the palpated vibration, and it should be the same on both sides. If I use a very quiet voice, you're not going to hear very much vibration. If I use a loud voice, you'll feel more vibration. But if there's a certain disease process in one lobe or another, you may feel something different asymmetrically side to side. So for instance, these two buckets of respiratory disease, consolidative and obstructive. In obstructive disease, something like asthma or COPD, I'm not getting as much air into my lungs. So when I speak, the vibrations that I am producing are fairly weak, and they might be diminished in an obstructive disease. In a consolidative disease, for instance, a pneumonia or a cancer tumor or tuberculosis, instead of fat, air-filled alveoli, I have either liquid or solid tissue. So I'm further into the solid end of the state of matter spectrum. Okay? Maybe I'm not all the way solid, but I'm consolidative. I'm further from the gas and into the liquid to solid area. Liquid and solid, as you know, transmits vibration stronger. To remember this concept, just imagine if I knock on this desk and you hear the sound through the air, you're going to hear a certain sound. But if you lie your ear on the desk and I make that same knock, it's going to be a lot stronger, right? Because the sound is traveling even stronger through the solid wood of the desk as opposed to just through the air. So if my hands are on the surface of tissue that's more solid than it should be, such as in a lung consolidative process, that vibration will also be stronger. And when I vocalize 99, 99, you're going to feel more vibration or more tactile fremitus, increased tactile fremitus over the area of that disease process. So tactile fremitus will be increased with consolidative processes and decreased with obstructive processes. We're going to use percussion next. Indirect percussion is usually what we use. Healthy adult lung tissue sounds resonant. If you're percussing your patient's lungs, remember, don't percuss over the scapula, don't percuss over the vertebra. Don't worry too much about being over the ribs or in the intercostal spaces. The ribs are small enough so you should probably hear the resonance of the lung tissue beyond it, as long as you're not over the larger bones. Inferior to the lungs, at the level of the diaphragm and below, you're going to hear dullness to percussion. That's how you know that's below the lungs or inferior to the lungs. Remember that when someone inhales, their diaphragm is going down, their chest is increasing in volume, and that dullness to percussion should be lower down on held inhalation than on a held exhalation, where the diaphragm is going to be higher up. You're going to hear that dullness to percussion higher up on the back. So what you're going to do is ask your patient to take a deep breath in and hold it. You're going to percuss down the lungs. You're going to hear resonance, 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 and a certain spot is going to change to dull. Mark that spot. Ask your patient to breathe normally. After a breath or two, ask them to take a deep breath in, blow it out, and hold it out. Now you're going to percuss. You're going to hear resonant, 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 and then dull again at a higher level than where you heard it change to dull before. Make sure you tell your patient to breathe normally when you found that spot and mark it off on their back in ink. You're going to go through the same process on the opposite side and compare the two areas. Normally in adult, you should have about 4 to 5 centimeters difference between the inhalation and exhalation. That's called diaphragmatic excursion. Now, depending on how serious they are in taking large breaths or blowing them all out, it might be a little on the higher side. Or if they're not taking it very seriously, they're not taking very big breaths, it might be a little less. However, if the size difference is very large, if one diaphragmatic excursion length distance is only 1 or 2 centimeters and the other one is 5 centimeters, you know that maybe one lung isn't able to expand. Or perhaps it's very decreased in both lungs. That person can't really expand their lungs. You know something is going on. The next part of the physical exam of the thorax is auscultation. Auscultation is really sort of the meat of the respiratory exam. We want to listen to the lungs. When you first practice listening to the lungs, you'll notice that the heart sounds are a lot louder than the lung sounds. The lung sounds are lower pitched, lower in volume. But with a little bit of practice, it'll be very easy to differentiate them and really ignore those heart sounds and concentrate on the lung sounds. For auscultation, we're going to do 2 basic pieces. We're going to listen for breath sounds, and then we're going to do a set of voice sound testing. For breath sounds, it's often easiest, especially as a beginner, to ask your patient to breathe with their mouth open, not to engage their vocal cords, but to breathe through their mouth while you're listening with your stethoscope on all of these areas of the lungs. What order you listen to the lungs in is a matter of debate. I don't think it's quite as important to direct you to start at the top and move to the bottom versus the bottom to the top, whichever you prefer. What is important is that you compare that one area on the left with the same corresponding area on the right. And then you move down and you compare that spot on the right with the corresponding area on the left. So you're comparing those 2 spots in all of the areas of the lungs. And then don't forget, you've got that right middle lobe that you've got to account for. It doesn't have a corresponding left middle lobe, but you want to really make sure that you listen in that area, on the anterior or the lateral side, because there could be a disease process happening in any one of those lobes that's not happening in the other. So make sure you listen to the posterior, anterior, and lateral aspects of the lungs. You'll notice when you first start listening to breath sounds that out in the alveoli area of the lungs and the parenchyma, you'll notice that the breath sounds are lower pitched and softer. Those are called vesicular sounds. Whereas if you listen sort of in the area of the sternum, you're going to hear more loud and higher pitched sounds. Those are bronchial sounds. And then there's sort of this middle area that you'll find a hybrid of the 2, bronchovesicular sounds. This distinction isn't really all that important diagnostically, but as a beginner, it's helpful for orienting you to the breath sounds. When listening to breath sounds in healthy lungs, we expect the breath sounds to sound clear. Clear breath sounds are like an easy breeze, like a breeze moving through treetops. If you find diminished or absent breath sounds in an area, that might mean that something is going on, like a pneumothorax, an area of the lung that's collapsed. So we're looking for clear breath sounds in all areas of the lungs. Besides the fact that you might hear no breath sounds or diminished breath sounds, you might hear what we call adventitious sounds or extra breath sounds. There are 3 main kinds of adventitious breath sounds: crackles, wheezes, and rubs. Crackles are discrete, non-continuous sounds. They're mostly heard on inhalation more than exhalation. And it usually implies that there are fluid bubbles popping within the alveoli. You can have either fine crackles or coarse crackles. Fine crackles sound a little like the Snap, Crackle, Pop cereal. Or if you take a little bit of hair and you rub it next to an ear, twist it between 2 fingers, you can hear little tiny, soft, non-continuous sounds. That sounds like fine crackles. Coarse crackles, on the other hand, are louder and lower in pitch. It sounds a little bit like Velcro opening. So they're still discontinuous sounds, but they're louder and lower. Wheezes, on the other hand, are a more continuous sound. Most of you have heard someone with asthma having wheezes. They're like a whistly, sometimes shrill, almost musical sound that's continuous. Wheezes tend to be more prominent on exhalation than inhalation. And then there's a certain kind of wheeze that is called a rhoncus, or the plural is rhonchi, that sounds more like a snore. So it's continuous and it's still on exhalation more than inhalation, but it's a louder, lower sound, like a snore. There is another kind of wheeze called a stridor that is the exception to the rule in that it's heard more on inspiration than expiration. It's a high-pitched sound. Think of a kid who has tried to swallow a Lego, but it's gone down the wrong tube. So something obstructing the upper airway. That's a stridor sound, stridor wheeze. Third kind of adventitious sound is rub. A rub sounds like if you put your boot down in fresh powdery snow. Or if you're not familiar with snow, imagine a 5-pound bag of flour and twist it. And that sound of the flour rubbing against each other is the way a rub sounds. It's sort of a grating sound. And it tends to occur on inspiration as well as expiration. It usually means that the pleura are rubbing against each other, either from inflammation or lack of fluid somehow in that pleural space. And for that reason, it's often associated with pain. You'll see rubs associated with pain frequently. So those are your adventitious sounds: crackles, wheezes, and rubs. We're going to listen to voice sounds. There are 3 types of voice sound tests that you're going to do: bronchophony, egophony, and whispered petroliloquy. You get 1 extra point in class if you can pronounce petroliloquy pretty quickly 3 times fast. In order to do the voice sound testing, you're going to place your stethoscope on all of these places on your patient's posterior, lateral, and anterior chest. And each time you place a stethoscope on them, you're going to ask them to vocalize a sound. In bronchophony, they're going to vocalize a multisyllabic word like 99 repeatedly each time you put your stethoscope on them. What we expect to hear on bronchophony is the vocalized sound, for instance 99, that sounds muffled and far away, distant and muffled, and the same left to right. Check all of these places on your patient's thorax, left and right sides, and also make sure you check in that right middle lobe. If on bronchophony the words are clearly heard and don't sound muffled and far away but closer, that's positive bronchophony, an abnormal finding, and it implies a consolidative process like pneumonia or a solid tumor in the area of the lungs at which your stethoscope picks up that louder bronchophony. Egophony is when you put your stethoscope on your patient's chest in all of these places and you ask them to pronounce the sound E, E, E each time you press your stethoscope on their skin. We expect to hear on the patient a muffled, distant E sound if that patient's lungs are healthy. If, on the other hand, they have an area of consolidative process, when your stethoscope is over that area, that E will sometimes change to an A sound. So it'll sound a little bit like A, 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 and it'll be louder and not so distant and muffled. An E to A change is positive egophony, and it also implies a consolidative process in that area of the lung. Whispered petroliloquy is having our patient whisper each time we put our stethoscope on their thorax. They'll whisper 1, 2, 3, 1, 2, 3 over and over again. And in normal lung tissue, without disease, you'll barely hear that whisper, or you might not hear anything at all through your stethoscope. However, if they have a consolidative process in a certain area of their lungs and they whisper 1, 2, 3, you'll hear in your stethoscope a very distinct 1, 2, 3 as if they're whispering right in your ear. It'll be louder and clear and like someone's whispering right there. It's creepy. That implies that they have a consolidative disease in that area of the lung. So to summarize the auscultation portion of the physical exam, you're going to listen for breath sounds, and then you're going to do voice sound testing. In reality, in practice, when you're further into your career, you won't be doing voice sound testing unless you have a particular concern. But for now, in order for you to have practice and make sure you know how to do these techniques all well so that you'll have them in your toolbox ready to go when you need them, we're going to have you practice them all, even on the healthy patients.